goes through the temporal lobe. The vision is not necessarily the occipital lobe. In fact, the occipital lobe wouldn't be affected. It's the visual radiation. Let me see. I think I. Let me see. Christian, can I see one of the PowerPoints?
Sure.
Can I see one of the diagrams? Yeah, that's a good point. It seems that the occipital lobe is involved and the temporal lobe is not involved. The temporal lobe is involved with memory, but the left temporal lobe is really dominant, and memory is reduplicated. So you can have a right temporal lobe lesion and not. Yeah, this is one. Yeah, I guess it doesn't show it, okay. Here's the primary motor strip, and face, hand, arm, and leg. Here's the sensory strip, same thing, face, arm, and leg. And here's the parietal lobe, which is the crossroads of the brain, where all sort of information is interpreted. The frontal lobe is sequencing. This is the left side because the language is involved. And the temporal lobe, it doesn't show here, but this is the occipital lobe, where there's the primary visual areas here. But there's what's called the optic radiation. Back of the genicular body, the radiation is here. So I'll tell you in this case that the visual radiation is affected, not the occipital lobe, which is supplied by different blood vessels. But it looks like the same thing. And also the parietal lobe, the difference between an occipital lobe lesion and a temporal parietal visual lesion is if you have an occipital lobe lesion, the person knows about it. If you have a parietal, temporal visual problem, the parietal lobe is not analyzing what's going on, and you're not aware. So you have the neglect. You don't know you've lost vision. If somebody has an occipital lobe lesion, they don't say I've lost left half of space, but they say something's the matter with my vision. It's blurry off on the left. So that's a good point. This is not, the lesion is not occipital. It is actually fronto. It's all here. It's primary motor strip, primary sensory cortex, parietal interpretive cortex, and the visual radiation in the temporal lobe. And the temporal lobe may be affected, but we can't pick up the memory because the left temporal lobe is dominant for memory. If you lose the left temporal lobe, then you're in trouble. Thank you.
So the fact that we didn't detect any olfactory problems or auditory problems doesn't necessarily indicate that temporal lobe is mostly okay.
Okay. Well, olfactory is something different. Olfactory is olfaction goes right to the temporal lobes. You're right, because that's why perfume and odors have such potent ability to make you remember things. But they're bilaterally represented. You almost never lose hearing from a central problem. Although there's Heschel's gyrus, which is the auditory interpretation area, it's so reduplicated that for our purposes, you don't notice it. If you have problem with olfaction, it's usually frontal lobe. That's the cranial nerve 1 we rarely check, but it's affected in Parkinson's disease, but the patients don't know it. They lose smell so gradually. But it's the nerve most injured after head injury, because these little filaments pass here through this sieve like cribriform plate. And so when you have a head injury and the brain moves back and forth inside the skull, all these little nerve filaments are torn, and to lose smell is very common after a head injury. So then we would check it. Routinely we don't check it because people usually have stuffy noses, and olfaction is really not lost from a central lesion, nor is hearing. It's got to be lost from the nerve, 8 or in this case 1. Okay, good. All right, next. Well, motor power.
Motor power was normal in the muscles of the right arm and left leg. He did not voluntarily lift his left leg off the bed, nor could he move his left hand or arm. Nevertheless, he denied that they were paralyzed.
Okay, so he's paralyzed and he doesn't know it. Okay, good. Next, read.
Reflexes.
deep tendon reflexes were hyperactive on the left side and not the right.
Okay, so there's a reflex arc, yeah.
Sorry, just going back to the previous statement, when he denies that they're paralyzed, does that mean he can't like comprehend that he can't move those muscles? Or like he knows that he can't move them but denies that like he's actually...
No, he's unaware. So they say, move your left side, it's over there. Move it. I'm moving it. No, you're not moving it. Yes, I am.
Okay.
Move it.
So his brain is giving him the sensation that he is moving it, but he's not actually
No, he feels nothing. That's why I try. The analogy is that you don't see behind your head. He has no information. He's going on memory. A few hours ago, I had a normal left side. I haven't gotten any information that anything is wrong, so it must be normal. So where? It's over there. And that's why with a trick, we had his father, where we say, reach, show me your, reach for your left side, and they'd say, it's over here somewhere. And then I hold it in my hand. And he says, that's it. That's it. But this is an acute phenomenon. Usually the next day, there's some improvement, and they start to notice what's going on. This is really the acute stage. The Eastchester clapping sign is acute. By the second day, it's gone. The person's gone. But this is really sick. All right? And the reflexes, hyperactivity. The reflexes are inhibited. There's the reflexes are. There's a reflex loop through the spinal cord, but there's cortical modulation of reflexes. When you have, the reflexes are. Here. All right, Will has a sleeve rolled up. Turn. You just hit like the biceps. You're like, relax.
We want to make sure you're okay.
Clench your teeth. It brings out the reflexes. Yeah, the reflexes aren't brisk. Actually, people who are strong usually, when I demonstrate the reflexes, I always take a woman from the audience, because women tend to have very brisk reflexes. And but what it would be is that the reflexes here would be the way Will's are, and on the left side they'd be really hyperactive. That means they're not inhibited by the cortex, by the brains and motor system. Yeah.
Why do you tap your own finger instead of...
Because it hurts.
Okay.
No, because I'm feeling the tendon.
I got you.
See, because there's a muscle reflex. If I hit the muscle, that's not the tendon reflex. So I'm feeling his biceps tendon. And I hit my finger. And this is very uncomfortable here. You're hitting right on the bone. So that's why I hit my own finger. Yeah?
Now, the reflex arc was damaged, but that's...
No, the reflex arc is intact. It's disinhibited.
Okay, and how is that affected by what's going on in the brain?
Because the brain inhibits certain things. For example, I didn't mention the Babinski reflex. There's a reflex that children have, and that it happens if you step on a nail, your foot automatically pulls away. Now, patients who have stroke, they have this Babinski reflex. When you stroke the bottom of the leg, it jumps up. This is normally inhibited. Probably an easier example is the bladder. The bladder has a rhythmicity when it fills, and it starts to contract. Now, there's an area in front of the lobe that says hold it until we finish. When that's damaged, you can't. The bladder becomes autonomous, and as soon as it's filled, it empties, and that's how patients get what's called urgency incontinence. It happens normally in older people. You can't hold it as much as you could before. So that's an example. There's a lot of modulation of spinal cord reflexes from up here. Same thing, breathing. Breathing is automatic, but you can adjust breathing by when you speak or sing. So this is just an example that the reflexes will be very brisk. Yes?
Can we just give a few minutes for questions? Because I know there's a little bit more here, but we only have like 7 minutes left.
Okay.
They may have other questions.
Okay, well, go ahead.
Just what we were saying before about trying to find body parts and things. Where is proprioception in the brain?
Proprioception is in joints, right? Okay. Proprioception then travels to the primary sensory area, and then is interpreted back of it in this posterior parietal area that we saw in the diagram.
Can you just define, I'm not sure if everybody knows what,
Proprioception means position sense. This is very important. You can see that you have proprioception in your feet, your knees, but you know, that's not that important because you can be above the knee amputee, and still use prostheses, but you got to have the proprioception in your hips. But proprioception is your test by moving your joint. Close your eyes. Tell me which way I'm moving your finger. Tell me whether it moves a little bit up or a little bit down. No, that was the example. Which way? Yeah. All right.
What actually was the issue?
Well,
Means gas.
I gave you, in this case, I'll give you this diagram. What happened was that he had a dissection. That's the most, 25% of strokes in young people are due to dissections. Here's a paper on a book chapter on stroke in sports, and it happens when you tear the lining of an artery and the blood goes under the wall of the artery and creates a false channel. And like so, here's the artery. And I stretch it, and it can happen spontaneously, or it happens in almost any sport, archery, football, rugby. What happens is you tear the lining, the intima, and the blood goes into the wall of the artery, and what happens is it blocks. This is the main channel, and here you have the fake channel. So you have two channels, and this big blood cut blocks dissects, it tears the layers apart, and blocks the artery.
How do you fix that?
So that becomes ischemic, or?
So what happens is that the blood flow is not just cut off, but bits of clot, bits of this stagnates, and bits block off. Let me see. No, and break off rather, and go up into the brain. And what happened here was that the embolus is here. Embolus, from Greek embolo, thrown in, right? So what happens is you have the dissection and a thrombosis, and at the site of the dissection, and the thrombus clot breaks off and embolizes here, and this is the left hemisphere, but the occlusion is here, and this is what I wanted to show you. Here's Meyer's loop. You can take that. Okay.
any last
Any
questions?
more of those,
Just one question, brought up from last week. I asked our last speaker about the future of science, and is it possible, or how soon do you think we will be able to reverse the effects that the stroke has on the brain? With like this neurotechnology that's coming out.
Well, I have no doubt that we will, but we can do it somewhat now with TPA, with a clot buster. But what we're looking for is a drug that we can administer to stop the damage that occurs, and we don't have that yet. There's a cascade. Once the cells stop pumping and once the cells die, they release